They're rarely terminal. They often will resolve themselves if you ride them out. So this is just important to bear in mind. So we're going to talk about some cases, all right? We've each got a few, some quick, some longer. Game over. So this is to the panel, really, okay? But actually, anybody, please shout out. We'll have questions afterwards as well. So this is a pretty routine pneumatic retinopexy presentation. Someone I thought would really benefit from a pneumatic retinopexy, a fairly large linear break there. In fact, this is a case I did myself. I wasn't aware of having multiple bubbles. On day 2, there is a little bit of gas under the retina. This is SF6. Is this a problem, do you think?
I don't think so. I mean, it's a small bubble. It'll go away. It looks like your retina has reattached.
Yes, I mean, yeah.
So I don't. This wouldn't faze me very much. I would do the laser as planned and.
Yeah, exactly. So I wasn't worried about this at all. As you can see, we have a much bigger volume of gas in front of the retina than under the retina, displacing the subretinal gas from the break. So long as the break is not being held open by the subretinal gas, it's not a problem, okay? And this was the successful course of this patient. It's terrible when you present your colleagues' cases, isn't it? But here we go. A large supranasal break. The gas was injected supratemporally. This was C3F8. My colleague couldn't get much out of the anterior chamber, so they put a gas in that expanded a little bit more slowly. They thought there was one bubble, but when the patient attended day 1 post-op, this is what we saw. So there has been, enormous passage of gas under the retina. This is super rare. I don't know, perhaps the use of C3F8 might predispose to this kind of problem. So, game over?
No, I mean, I think that, I agree a small bubble of C3F8 is more likely to cause this. The first thing I would do is try to express the gas through the retinal break with scleral depression. I think that you can try to squeeze it out, and if you can do that, you would be fine because the bubble will have now expanded, so it would be less likely to go back underneath.
Yeah, so this massive passage of gas under the retina, unless something has wildly gone wrong, means the gas could probably get out as well. So we put the lady on her back. 20 minutes later, the gas had come forward. We put her on her side for a few hours to allow the bubble to sort of become a little bit larger. We were a bit fearful of going back, putting the gas anywhere near the break for fear that would happen again. But as you can see, day 2, the retina's reattaching. Day 3, the retina's fully reattached. This slower coalescence of this C3F8, which coalesces a little bit more slowly.
Roxanne, I would just add, if you have a situation like that and you've managed to tease the gas out from the subretinal space and you have still multiple bubbles, I think it's a good idea to position those patients face down.
Okay.
As the bubble expands, it will coalesce, and then it'll be less of a risk. But usually, if I'm in a situation like this, I'll position them face down overnight.
So we were so surprised and disappointed by this. We actually put her on her side overnight. Her macula had been off for a couple of weeks in any case, and then it was one bubble. Then we put her on her face. But yeah, we did respect the principle of keeping it away from the break for a time. 5 months later, this is how she ended up. So another case, break in the supratemporal quadrant. We had some lattice infratemporally. This was, again, a case of my colleague, giving the game away now. The principle here would be to apply a prophylactic laser to the lattice and posture the patient such that we prevent the fluid from displacing infratemporally. Face-down positioning, position on the left-hand side, then move to tamponade the break. So, on day 2, this should have been a complete shoo-in, is what we would say in England. It should have worked. What's this? What's going on? Is this game over?
It'll still work.
Yeah, I mean, this is some hot laser. You wonder if the laser was done after was.
No, so this is the really interesting thing. So
okay.
Of course, hot laser through any amount of fluid, or actually any laser through any amount of fluid risks punching holes. But this was dry retina. So my understanding was that we had displacement of the fluid after, hot or not, that it had been applied. So the eternal optimist, I thought, do you know what? I don't think there was a break here before. It may well not be recruiting. The lady's macula is back on. Let's just see how this goes, okay? I think if this had been hot laser through fluid, that would have been different. And actually, I watched her every couple of days. By day 14, the retina was fully reattached. I couldn't resist adding a little bit more laser at this stage, but by week 4, it had resolved. So I just want to demonstrate to you how seemingly scary things can happen, but in fact, because it's a minimally invasive technique, you can usually work around it.
Thank you. So let's see by the book case. I'm not that extreme as Rajiv and Peter. Come on, why are you laughing? It's okay, smiling. Okay. So that's a 45 years old male who was referred for reduced vision in the right eye for 2 days. His past medical history was negative, and he had myopia of around -5 diopters. So on examination, 660 visual acuity in the right eye and 660 in the left eye. Anterior segments okay, intraocular pressure was fine. Posterior segments, the left eye was flat with no breaks. I love drawings, so I always draw. So in the right eye, the case is that we have an inferotemporal retina detachment. This is with scleral depression. We have a superotemporal extensive lattice, and we have one break, superonasal, on attached retina. And that's the baseline OCT with those lovely corrugations that Rajiv explained during the previous course. So we know that this is more than 2 days retina detachment. So I decided to proceed with a pneumatic, as by the book Pivot Guidelines. I lasered the lattice, the superotemporal lattice, and the superonasal flat break on flat retina. So this is before the initiation of the pneumatic retinopexy. I performed a cryo to the temporal break on detached retina, and as you can see here, I withdraw 0.4 cc's of aqueous from the anterior chamber. The plunger is off, so it happens passively, and I hold a Q-tip on the other side to counterpress very slowly, so I facilitate the passive withdrawal of the aqueous, and that is the AC paracentesis. And then I mark 4 millimeters from the limbus, and I eject 0.6 of SF6 superotemporally. As you see, the eye is quite soft, and I insert and then I withdraw, so only the tiny tip of the needle is in the eye, so I can achieve one single bubble. This is first day through my 28 diopters in direct ophthalmoscope. The bubble is unique, one bubble, and this is 2 days, so you can see some bubbles of fluid, but in 6 months they have completely resolved. Visual acuity 6.6 in that eye, and this is the final outcome with my cryopexy on the temporal break and the lasers on the superotemporal and supernasal pathology. Thank you so much for your attention.
Okay, some more complex cases now. So this is a patient who has a choroidal detachment and a superior retinal break. These are ideal for pneumatic retinopexy because surgery can be quite complicated when you have a choroidal detachment there. But by injecting a gas bubble, you can address both issues, the hypotony and the break. And so here you can see over the next day, the retina was starting to attach, the choroidal was going to resolve, and the laser was applied around the superior break. So now we're going to try to talk about a few additional cases here. I'll call on Peter to discuss his first case, and then I have one after that.
Thanks, Rajiv. So this is this first patient is a 58-year-old Asian male with who's a moderate myope, who's had 5 days. Actually, he's had a few weeks of symptoms and has come in with this inferior retinal detachment. And to be fair, I mean, I know people are shaking their heads and wondering, this is not a good patient for a pneumatic. And when I didn't look at the picture before I decided to do a pneumatic on this patient. I looked at the patient, and I really thought the break was more at 5 o'clock rather than 6 o'clock. But looking at the picture, it really does look like that tear is right underneath the optic nerve. So, anyway, we elected to do, this is a very motivated patient. He understood the process, he understood the principles involved, and was very motivated to avoid surgery. So we did a pneumatic. He positioned himself face down. We were able to get 0.7 cc's in. So when we saw him on the first, at the first post-pneumatic visit, we were able to get a lot of the laser in, maybe 80% of the laser, but he still had some anterior retinal detachment. So we positioned him a bit longer. Oops, sorry. Can I go back? Sorry. So we positioned him a bit longer. We were able to get, so this is after a second pneumatic, a double bubble as we've come to like to call it, and his retina is fully attached and we're able to complete the laser. And his vision has stayed 20/20. So this is another patient, a 49-year-old male who's phakic with good vision, moderate myope, came in complaining of a visual defect over the preceding day. And this is what his retina looked like. So he had, so you can see the drawing on the lower right, he had 10 breaks in total from about, some of which were in attached retina, a couple of which were in attached retina inferiorly and infratemporally, but others that spanned his retinal detachment basically from 9 o'clock to 3 o'clock. So we lasered the breaks in attached retina, arguably a little too energetically, but this was done before the injection of gas. The gas was injected and we prioritized the macula and those temporal breaks. And once those were reattached, we lasered those and we sort of sequentially moved him around until we were able to get his entire retina attached and all his breaks treated with laser.
Great, and we'll just end with one last case. So this is a patient with a giant retinal tear, 10:2. You can see the retina is pretty much folded over. And, GRTs, paradoxically, are actually easier to fix with pneumatic than some would think, because as soon as you put the gas bubble, as long as you can put the bubble away from the tear, the buoyant force of the bubble is so substantial with face-down positioning that it'll unfold that retina very quickly. And in fact, with 15 minutes of face-down positioning, the retina had largely unfolded. Here you can see at day 1, the whole temporal side of the GRT had unfolded. We started our temporal laser around the inferior edge of the GRT, and here you can see additional laser that's been applied. There was still some nasal fluid from the nasal end of the GRT. So once I had lasered the whole superior and temporal side, what I decided to do was I was really only worried about the horns. So I was positioning him on the left side for 2 hours and then alternating with right side for 4 hours so I could secure those 2 horns. And this allowed me to then complete the laser completely around the retinal break and achieve a complete attachment. And if we look at the fundus autofluorescence image, you don't see any evidence of retinal displacement. And in giant retinal tears, when you do a vitrectomy, there's substantial risk of slippage and other anatomic abnormalities. And slippage is impossible with pneumatic retinopexy because of the mechanism of action of retinal detachment repair. So with that, we're going to end the course here, and we're just going to discuss, have some questions and answers.
We thank you so much. Those cases were amazing. I should say that I do about 40% of my detachments with pneumatic retinopexy, and I'm much more pedestrian. It's firmly embedded in my practice. But, some of the cases you've seen, we've tried to give you the full range of how you can implement pneumatic retinopexy, but of course these are probably not cases you would start with. So yeah, we have got some discussion time now. We have had some come through online, but we'd be very pleased to take any questions that anybody has. Just come up to the mic if so. Somebody, oh, apologies, sorry, I didn't see.
Yes.
Good evening. Thank you for this very nice presentation. I want to ask, although this technique looks very simple, easy, outpatient technique, not gaining much popularity nowadays. Why this, although it is a very excellent technique and with very good results?
Go ahead. We talk about this a lot. It's a fantastic question, and it's the subject, in fact, of a qualitative study that we're carrying out in the UK because it's an interesting phenomena. There's some data, but there's clearly some hesitation to take up the technique. I think it may be partly cultural, as in what you're used to, what you were taught, partly lack of mentorship. Perhaps we need more clinical evidence. I think it's multifactorial. Do you have any thoughts on that?
Yeah, I mean, I think that there is a change that's taking place. I've definitely seen a greater uptake in different parts of the world, particularly among junior colleagues, I would say. So surgeons that are under 50 years old, you know, if I post a case of a retinal detachment, usually about half of them would do a pneumatic retinopexy in the United States and Canada. And in different parts of the world, it's starting to increase. You know, I think that there's a history of pneumatic retinopexy that where the technique was very different at that time than what we do now, in the sense of some of the changes we've been all advocating, you know, in terms of extra gas bubbles, you know, when we apply cryo and laser, how we position patients. You know, now we're using ultra-wide field imaging and OCT to assist. All of these things have improved our attachment rates and improved outcomes, and particularly with the integrity displacement, the greater awareness of this, I think for the newer generation of retinal surgeons, it's becoming, I think, an essential technique. So, you know, I think that it's going to take time. They say it takes 17 years for clinical trial data to permeate through clinical practice. It's been 4 years since the pneumatic retinopexy trial, since the PIVOT trial, and I think we are seeing a change, but it's slow.
Yeah, I mean, I should say, if anybody, we mentioned we have this large Telegram group. I think there's near on 700 folk that participate in that. So there is some interest. If anybody, I think it probably speak for yourself, we'd be very pleased for you to reach out. We'd be personally very happy to support you in your uptake of the technique. So whichever side of the Atlantic you're on, you might see who you get in touch with, but please reach out. Hi, David. Thank you.
You've shown us some extraordinary cases, which, you know, I absolutely bow to your expertise in getting some of those flat with a pneumatic. But for those of us in the UK and Western Europe who are just embarking on our pneumatic journey, what can you give us some advice? What's the best one to start with? What's the kind of detachment that you're going to get nearly 90% success rate with doing a pneumatic? Because that's what we've got to start with if we're going to win over our colleagues.
Exactly.
I mean, I think with a careful examination, if you can identify that the morphology of the detachment fulfills the pivot criteria, so, you know, perhaps 1 break, 2 breaks within 1 clock hour, a compliant patient in the sense they are on this journey with you. I think it's also worth thinking about who would benefit the most. So patients with a macular off, you know, a phakic patient, these are the patients that are likely to benefit the most. So, I mean, I actually think if you stick to the, you know, the ethos that the preoperative examination is key, you cannot go too far wrong. It's the hidden pathology that will catch you out.
And I'd like to add, one of our fellows, Aurora Pakaku, she presented data today on patients who had a single break. So let's say you have a single break in detached retina, only taking data from either randomized or prospective clinical trials. We compared the risk of anatomic failure with pneumatic versus vitrectomy. And in single break detachments, your primary single operation reattachment rate was 88% with pneumatic and 92% or 91% with vitrectomy. So a 3% difference, but so many advantages. So if you're going to start with one where you can basically have the same reattachment rate with all the advantages, a single break detachment would be a great way to start.
And then logistically, working in the NHS as you do, you know, this is a tight system. We have a heavy workload. Sometimes, you know, the slightly shallower detachment where you might do a 1-step cryo-pneumatic, you might find logistically that's the easier entry point just in terms of logistics as well.
The ones that I like doing, and you know, I suggest to the patient that this is what we should do, is young patients, phakic, myopic, shallow detachment, small break. That's it. I cryo the break in the OR, and then AC paracentesis of the gas. That's it. And of course, you say that they have to be psychologically prepared to be in specific position. So that's, I think, they are the ideal cases to start with.
And I think you'll find, like, pneumatic retinopexy is a bit like crack. Once you start doing them and you see these fantastic successes, you'll go above and beyond.
Yeah, where does it end?
Yeah, can be very gratifying.
I mean, it is, to add to that, I mean, when, we showed those crazy cases to show, so that when you see a single superior horseshoe tear, you're going to say, well, maybe I should do a pneumatic, but it is, the most satisfying thing in my practice right now is getting a GRT like that and fixing it without surgery. I mean, that gives me a thrill even 15 years down the road, but yes.
Thank you. I'm convinced I need to try this technique for a lot of cases. But I have a problem because I don't have a laser linked on a helmet, because in France we don't do that much. And do you think it's doable with a slit lamp laser?
It's doable, not optimal. So I think you could do a cryopneumatic. You can laser with a bit of careful positioning certain breaks through the slit lamp, but it's a challenge. It's a challenge.
Yeah.
So I think if you were wanting to take on the breadth of even pedestrian, I'm calling the straightforward pneumatics, I think access to indirect laser is the ideal situation. It's not insurmountable,
It's nice to have options, so you might find that, at the slit lamp laser, you're kind of, it's the meniscus that's the problem. If there are breaks at 3 and 9 o'clock below the gas, those are easy to treat at the slit lamp. If it's a break at 12 o'clock, it's easy to treat at with a slit lamp laser, but it's those meniscus breaks that can be a challenge. So you can certainly use a slit lamp laser, but you want to have some options.
Yeah, I mean, I should say, when you do so say you don't have the laser, when you do a pneumatic as your first pass procedure, we didn't have time to incorporate it today, but if you have to do a subsequent vitrectomy, there is no particular challenge or difficulty. If anything, you've put most of their retina on. A pneumatic never fails outright. It just sometimes doesn't quite work. And if that's because of lack of an indirect, and you're struggling, it's not the end of the world. The patient is not going to be any worse off, and they might be a lot better off.
Yeah, and I'd like to add that, there's this, I think, a misconception that when you put a gas bubble in an eye, you're going to cause new breaks and PVR. This is the old kind of mentality. And what we've found is that in our randomized trials, we've seen no greater risk of new breaks or PVR in patients, even incorporating the failed pneumatics. But the caveat is, when you have a failed pneumatic, you have to treat it. So, if it's Thursday and you're going to EU Retina and you have a failed pneumatic there, and your next OR day is the following Friday, that's a recipe for a disaster, because you're leaving a detached retina with a bubble in there for 10 days and then operating on them. So I would say that when you have a failed pneumatic, it's very important to keep them face down in phakic patients to keep the bubble away from the lens. And I suggest repair within 3 days maximum for a failed pneumatic.
Now, a possible way to do a pneumatic without having an indirect is you can put them in the OR, you put a chandelier with a small trocar, and then you do the cryo through the biome, and then you proceed. It is.
I guess.
Why don't you just do the vitrectomy?
Yeah, that's overkill, yeah.
So, and then AC paracentesis and gas bubble, that's it. So instead of the indirect, you use the biome and the chandelier to do your cryo, that's it. Yeah.
I mean, if you're not comfortable with indirect ophthalmoscopy,
Better not to do pneumatic.
better not to do
I think they're hand
know.
in hand.
Yeah, I mean, that said though, Peter, I think there's a lot of places in the world that don't do a lot of indirect. I mean, I think the American, Canadian, and British systems are very indirect laser heavy, but I've been to many parts of the world where slit lamp laser is really the only thing.
I'm not talking about indirect, I'm talking about indirect, I'm talking about
indirect
use of an indirect. Yeah.
Okay,
Yeah.
all right, well,
I mean, if you have to put a chandelier,
But even that, but I think that with slit lamp, you can get most of it. I know a lot of colleagues who are doing a fair number of pneumatics with slit lamp, but I personally feel like you should invest in the indirect laser and yeah. But.
Hi, I have a question. You showed the beautiful cases, in particular in pediatric, some pediatric ones. What would you say to some colleagues that have concern about injecting bubbles in patients with PVD that is not done? because of the concern of the brakes and stuff.
Yeah, so this is a really interesting concept as well that's been kind of touted in the past as a reason not to do pneumatics in general, that when you have a formed vitreous, then you inject bubble, you're going to induce brake, and you see these classic pictures of the bubble and the vitreous being pulled. And now we have ultra wide field swept source OCT. We can actually image the vitreous inferiorly when you have a gas bubble superiorly, and we don't see anything like that. In fact, there's no change in the conformation of tractional areas or the dynamics of vitreous traction on the inferior retina as far. And you would think that we would have a pandemic of new breaks forming in patients with attached hyaloid and this, but we really don't see this. And in fact, I think that in children, when you have a formed vitreous, just putting the bubble in probably shifts the vitreous around, and the vitreous itself will plug the break. So many times we have a large break and a bubble that's smaller than the break itself, and you're able to achieve attachment. So for example, in that patient, that the child with the large dialysis, we ended up putting 2 gas bubbles in the eye. But in my experience, this, the fear of causing new breaks from gas is not something that really happens in my practice. But
Yeah, I totally. I mean, there are a lot of myths surrounding pediatric pneumatic retinopexy in the setting of pediatric detachments. Your point about patients without a posterior vitreous detachment, it's true for even adults without a PVD. It really doesn't make any difference. The fact people don't think children will listen. They're with parents and children. Like the kids are like the most compliant. With games, they love having their head down. They love having their face down. Face down works for everything. So, I think people don't think of pneumatic retinopexy in the setting of pediatric detachments, but I think often they should.
I will say with gas in situ, apologies for this. I will say with gas in situ, as well as positioning, even if the break is at 12, I will ask patients to be still. So just because they're upright, they can't be running around doing stuff. Because I think actually tumbling the bubble around in formed vitreous is possibly tempting fate.
And I also think that if you don't have a PVD, your hyaloid is attached, whether you do a vitrectomy, a buccal, or a pneumatic, eventually that vitreous will separate. Now, whether you do it during vitrectomy and you induce a PVD, whether you do a buccal and the patient has a PVD a year later, or with a pneumatic, we've found that when we take patients with attached hyaloid, about 50% of them in the older age group will get a separation of their hyaloid within 1 month. So the only slight thing that we've changed is that we may examine those patients a little more thoroughly in the first month, anticipating a PVD, and so that if another break occurs from the PVD, that we can treat it. Yeah.
You just said that you have images of the vitreous after you put bubbles. Did you publish the imaging of this of the vitreous after putting a bubble in it?
Yes, so we use the Silverstone Optos, the ultra-wide field swept source OCT, so we can image very peripheral vitreous. And if you take patients who have lattice degeneration, those patients with inferior lattice will have traction all along the edge of the lattice, and you can actually see the strands of vitreous, their orientation and everything. So what we did is we applied laser to those regions, and then we injected the gas, and then we imaged the patient sequentially over time, and you can actually see the conformation of the traction, and it's essentially unchanged in the presence of gas, whereas you would expect that with that buoyant force causing traction, as we've seen in these older reports, that you would expect that you would change and you would see some evidence of vitreous traction. So that's something that we've now been using to study this more.
So let me see where we are for time. Yeah, I suppose we have some online questions. Possibly we are a little over time. So we probably should respect that. But I'd be very happy to answer. I mean, what do you think?
So I think we can...
and we'll stick around. We'll stick around if anyone has questions for us.
Yeah, so Peter, I'll just ask you, how would you decide between SF6 and C3F8?
I mean, I don't think there's anything wrong with C3F8. I like the fact that SF6, reaches its maximum volume at, by 36 hours. So you have a pretty good idea, at the... I like to see them 2 days after the pneumatic. you have a pretty good idea at 2 days whether this is going to fly or not. Whereas the C3F8 takes 4 days to expand, and it sticks around for a month. You don't need the gas for a month. You know, the SF6 lasts for 9 to 10 days, and that's almost always more than adequate.
And Roxanne, can you elaborate on how to go about with alternate positioning? So you have breaks that are more than 3 clock hours apart. How do you actually?
Yeah, so for example, the case, Peter's case with the 3 breaks there, that's readily achievable. I mean, sometimes one might need a double bubble. With a single bubble, I will generally focus on the macula. I will then generally focus on the most inferior break. I will steamroll to the most inferior break as the bubble expands. And then perhaps at 1 or 2 days after the gas injection, once that area is reattached, I will laser it and then alter the position. So I either will sequentially deal with the detachment, or once everything's attached, I will then alternate. It might be 2 hours this way, 2 hours that way. So in this way, you can use one bubble over a wider area. I don't know if that replicates roughly what you do.
Yeah, no, I think that's exactly. So it probably would be better to describe it as sequential and then alternate position. We don't alternate at the outset. We sequentially reattach the retina, and then once it's attached, just while the gas is there, try and alternate the position. So sequential is probably a better term.
This is a good question.
Yeah. So how much time prior to the pneumatic would you do laser? So for the attached area. So when, Emmanuel? When?
Immediately.
Right.
No problem.
Yeah, exactly. So you want to do it right away. You don't have to wait and the next day.
Yeah, as long as it takes to walk from the laser room to my lane.
Yeah. So, and Peter, how do you want to just elaborate on fish eggs? Just any tips, additional tips on how to prevent fish eggs?
Yeah, I mean, I think in your description of the technique, I think it came across in all our talks. The important thing, you always want to be injecting into an ever-expanding bubble. So you do your injection, you put your needle in the eye, and you pull it back so that you're always injecting into an ever-expanding bubble. Like people, worry about these bullous superior detachments, so they inject inferiorly. For sure, if you're injecting inferiorly, you're going to get fish eggs. So I like to go supratemporally, and the key is not to have your needle too deep into the eye. Just pull it back. So just really the hub of the needle is in the vitreous, and then you're injecting into an ever-expanding bubble. And the fears about bullous detachments and big tears, I think, I don't think you have to fear these things. I think can easily be done safely and well with a consistent, proper technique.
Another question here is, what is the rate of redetachment? So, everything looks good, the laser's in place, and then they come back 2 weeks, 3 weeks later with a detachment again. So this, I can tell you some of the data that's out there that from the clinical trials, once a patient achieves retinal reattachment, specifically at 3 months, once the retina is attached, it's extremely unlikely for it to redetach. So we had in the PIVOT trial 1 redetachment in the pneumatic group and 2 in the vitrectomy group between 3 months and a year. And recently, our group is just looking at the long-term data out to 5, 6, 7 years out, and almost none of them have redetached. So once you get an attachment and it's lasered, it's a very durable attachment.
Definitely.
I think it's David Yorson I always quote his paper from long ago where he said that 95% of attachments at 2 months, I believe. So if they make it to 2 months, I tell them not to pop the cork on the champagne until they've made it to 2 months. But
and I say 1 month. Yeah.
Okay.
For me, it's almost like failure to reattach rather than reattachment and then failure. That's what I tend to see.
Yeah, Roxanne, maybe the last question, or would a paracentesis blade be better to do an AC tap rather than a needle?
I mean, I think if you just want to harvest a couple of drops of aqueous for a different purpose, that's entirely reasonable. But where you are trying to harvest every last drop of aqueous, you need a very controlled situation where you are maintaining the pressure and the convexity of the cornea for as long as possible. So this sort of bimanual technique where you're applying pressure just behind the limbus and then harvesting through a 30-gauge needle works very, very well. The other thing is, of course, you have the peripheral iris plugging any peripheral limbal incision, whereas you can navigate your needle closer to the pupillary margin where the AC will remain deep. So, I mean, that's a way of doing it for sure. But if you want to use SF6, which will only double in size, you need to put a decent volume in, which means you need to get a decent amount of aqueous out.
It's good to know the volume that you've taken out. So
As well,
I
true,
always,
true, yeah,
I always inject 0.3 more than I've taken out. So there are times you can take out more than 0.3. I think there's value to knowing how much you've been able to take out.
And JP asked, you have a nice sweater, but aren't you worried about endophthalmitis? I think you saw, he was talking about my video where I had no gloves on. You know, in Canada, we don't use gloves for intravitreal injections at all. And, you know, we consider pneumatic retinopexy essentially an intravitreal injection. So in North America, the practice patterns are pretty much not to use gloves for most intravitreal injections. So that's what we do for pneumatic retinopexy. I think in other parts of the world, it's done in the operating room, so probably the...
Yeah, I mean, there's another question here saying, where do you do the procedures? So obviously I did some fellowship training in Canada, and it's really just done in a regular clinic room. In the UK, I mean, Europe, it's different. In the UK, we need a certain minimum amount of air exchanges taking place in the room. So an intravitreal injection has to be done in a bespoke room. Pneumatic doesn't have to be done in the operating theatre, but in the UK, it would need to be done in one of these clean rooms, but not in the operating theatre. It's really what the regulation around your healthcare service will support, you know.
Great.
I think so. I think
Yeah.
we've been, you know, generously eaten into your time. So thank you so much.
Thank you.